Let's get back together and move on. Here we're going to talk about treatment. So treatment of depression and anxiety is also a very large and diverse topic. This is what people think about when they think of treatment. But that's old-fashioned. So currently, we have better treatments than lasting on the couch. So this is how many people get treated for depression among adults. So 44% are seeing a mental health professional and are on medication. 6% are on medication alone. And then some are just seeing a mental health professional for some sort of psychotherapy alone, but 35% have no treatment. So we at Rogers, so I've been at Rogers for many years, so it's also the way I think, is we focus on evidence-based treatment. Evidence-based treatment means that you can demonstrate its efficacy in some sort of controlled scientific way, meaning that you have a control group and you have a treatment group, and it should be double-blind. So among evidence-based treatments, and this is not all of them, the most commonly recognized for depression are cognitive behavioral therapy, behavioral activation, medication. Anxiety is similar, cognitive behavioral therapy, exposure-based treatment, so that's exposure and response prevention for OCD, but there are other exposure-based treatments for other anxiety disorders, and then medication again. So this is just the basic cognitive behavioral model for anxiety. So cognitive CBT is what it's called. So cognitive behavioral therapy means that the client, the person and their guide or their therapist would be looking at the relationships between emotions and thoughts and behaviors, with the idea being that well, physical feelings you can throw in with emotions, but the idea is that we don't have a lot of control over our emotions. They just are what they are, and actually accepting emotions as what they are is sort of helpful. We have a lot of control over our behaviors. Those are our choices. It's what we do. We have very much control over that, and we have more control over our thoughts than most of us think. So that's really the crux of CBT. So Aaron back many decades ago originated cognitive therapy. So that's just the C part, the focusing on cognitions. And he believed that depression occurred because of unhealthy, faulty, or distorted views about oneself or about the world or about the future. So in cognitive therapy, and then by extension in cognitive behavioral therapy, one important part is looking at those thoughts that we have more control over than we usually think. So they use terms like automatic thoughts, that those are the thoughts that occur immediately, spontaneously in response to situations. Schemas are the kind of the narratives we have in our heads about the world, or our core beliefs about ourselves, about the world, about the future. It's much harder to change a core belief or a schema because you've held it for a really long time, you believe strongly in it, but you don't always recognize it's there. So they're very enduring. Cognitive distortions are automatic thoughts that grow out of those distorted core beliefs. So cognitive distortions include things like catastrophizing, so assuming the worst will happen. You probably know people who always assume the worst. It's not a healthy way to think. So everybody has cognitive distortions. I have cognitive distortions. I benefit from knowing what mine are, and I think I don't know all of them, but so any one of us benefits from knowing what our distortions are that we commonly fall into when we're stressed. So you might notice that when you're having a bad day at work, or you're just on your last nerve, you would engage in catastrophizing or emotional reasoning that feelings are fact. Because I feel, down, I'm a bad person. All or nothing thinking is another one. Mental filtering, that would be noticing preferentially the bad things that have happened in your day, or the negative events that have occurred, and discounting or not paying much attention at all to those positive things that have occurred. Very common in depressed people. Mind reading, which is what it sounds like. I think I know what you're thinking, and I think you're thinking that this is a bad presentation. That's the kind of mind reading that gets us into trouble. Labeling, bad person, good person, is another cognitive distortion. Should, must, if you listen to people talk, some people talk a lot in shoulds. You should do this, I should do that. Minimization or maximization, sort of what it sounds like. So addressing, recognizing cognitive distortions and learning to balance thinking is part of cognitive therapy. It's very effective for both depression and anxiety. Cognitive errors that are specific to anxiety, they're not the only ones, but catastrophizing, so people who are anxious tend to assume the worst. And that includes probability overestimation, so assuming that worst outcome is the most likely outcome. So if you really think about it, this roof could cave in, and that is actually a possibility right now. It's not a high likelihood. I mean, it's not going to occur. I'm perfectly confident, but it could. So that's an extreme example that people who tend to overestimate probabilities because of their anxiety assume those bad things are the most likely things to occur, or very likely to occur. So exposure and response prevention treatment is specific for OCD. It's the gold standard. So actually, if you have mild to moderate OCD, that's where you should go first. It's hard to find though. And it's labor intensive. It takes a lot of person effort, not therapist effort, that too, but this is work. So exposures, that's when somebody purposely but systematically and planfully exposes themselves repeatedly to the stimulus that causes the anxiety. So that could be an object, it could be a person, it could be a thought. And then they do repeated trials, and anxiety gradually comes down. So the most common example in most of our lives is, if you don't like public speaking, you tend to avoid it and you feel better, but you don't get any better at public speaking. So this would be exposure-based treatment for social anxiety, performance anxiety specifically. The treatment is exposing yourself to those situations in which you have to speak in front of a group of people, but you'd start small with maybe some people in your family and reading a paragraph out loud, and you would progress to the point of what you had once thought was impossible by just repetitive doing. So for OCD, that works the same way, but it's not just the exposure. The other half, very important, is the response prevention. So you expose yourself to the thing that causes the anxiety without doing whatever the ritual is that reduces that anxiety. So this is typical OCD scenario. There's a trigger, your anxiety goes way up, you then do the ritual, and your anxiety plummets. Over time, it's less and less effective, but you might add other rituals, so you're doing 1, 2, or 3 rituals in response to any trigger. So this is exposure and response prevention. There's no response or compulsion performed. And over time, and it's not a lot of time, it's minutes usually, people habituate to the anxiety. So the idea is you do repetitive trials, so you expose yourself to that same stimulus repetitively, and that means in the same day. And you gradually have lower peaks and a more rapid time to habituation. So that's exposure and response prevention, but exposure-based treatment is the same idea, confronting fears, but it can be applied very effectively to generalized anxiety disorder, to panic disorder, and social anxiety disorder. So with generalized anxiety disorders, they generally make imaginal scripts or real scripts they make scripts about their core fears and imagine those things, or they put themselves in situations which cause their anxiety. Intolerance of uncertainty refers to as a very common feature of generalized anxiety disorder. People with that disorder have a lot of difficulty tolerating unknowns like the future, which is unknown to all of us, unfortunately. They might do exposures where they're just making a phone call to a friend. They might propose outings with friends. They might limit the amount of time they spend on their homework. Panic disorder, there's a specific type of exposure for panic disorders called interoceptive exposures. So in those, you basically identify the features of your panic, so those physiologic symptoms, and you isolate them and you induce them on purpose, starting with the ones that are least like your panic experience and progressing to the ones that are most like your panic experience over time. So for instance, shortness of breath is a common symptom of a panic attack. So people who are doing interoceptive exposures might breathe through a straw, and not just one of those big dangerous straws, the coffee straws, which, you know, those little ones. It's really, try it. It's not easy to do, but that induces that symptom, and they gradually habituate to that symptom of panic, and they move on to another one. It defangs panic. So as they become confident that those symptoms, they've habituated to those, the panic attacks may occur, but they become less and less and less in terms of severity. Social anxiety disorder, those people do exposures like calling a business and asking a silly question, or, well, they start with calling business, because many people with social anxiety disorder won't call a business. Then they might call and ask a ridiculous question, like a shoe store, calling and asking if they have pork loin. And then they do other things like wearing conspicuous clothing or embarrassing clothing in public. They do presentations. They do a lot of exposures that are, again, repetitive tasks that help them habituate to their anxiety, and they start, so all exposure work should be hierarchical, meaning that you identify the worst things, and then you identify the easy things to the worst things, and you start in the middle where it's challenging but not overwhelming.
And should this always be done under the practice of a therapist? Or, you know, you're not saying go home and try this if you have a little anxiety? Or does it depend?
Oh, it depends, because knowing this, if you have social anxiety and you have a fear of public speaking, volunteer for things, that's an exposure, but you do it repetitively, you know. If you have really severe OCD, it's probably not gonna work, and you need to have the help of a professional. So for many of these, that would be true. Less severe disease, you know, do it at home. These aren't dangerous. Anxiety is not dangerous. It's temporary, not an emergency. But, you know, the interoceptive exposures would be hard to create and do at home. The great thing about CBT is that you see a therapist for a while, you construct this stuff, you know how to do it, you keep doing it in your life. It becomes a pattern of thinking. You recognize your cognitive distortions. If it's, you know, you're treating depression or anxiety, you recognize those things and you know how to balance the thoughts so they become less powerful in your life and less disabling. So cognitive behavioral therapy is a long-term benefit because you invest some effort and time, and you might need to practice again later in your life, but it's like playing the piano. You take lessons and you get good, you lose skill over time, you don't practice enough, and you need to go back and take some more lessons and get better again. I think CBT is much the same. So back to the Yerkes-Dodson curve, that's just what I was saying. We want to target exposures at the the mid-range, maybe beyond the mid-range, but we want to target them so they're not overwhelming and inducing panic, but are challenging. Because, you know, again, on TV, it's great to throw the person who's scared of water into the pool. It doesn't help people who are scared of water. Behavioral activation is an evidence-based treatment for depression. Yes?
Yeah, I was wondering if there are any physical measurements that would let people know where they were on the curve, you know, and you could wear it as in an iPhone app or something, and it would help you throughout the day. Is that at all possible or too complicated? You need EEG and...
Well, it sounds complicated. You wouldn't need, you could just do can't even remember the name of it, but you can monitor heart rate and for instance, by a little finger.
Yeah.
So, and iPhones can do just about anything. So I don't know the answer to your question, but
have people like found combinations of heart rate variability and you know, if there were a way of conveniently monitoring your EEG, or is it still something into the future? You know, would having a tool like that be helpful?
Well, I think it's overkill, because just knowing that when you're knowing that when your anxiety is moderate, you feel this way versus when
Okay.
it's high, you feel this way, helps you just function in that realm of not too much anxiety.
Alright.
But it probably wouldn't be very hard to figure it out using your heart rate, and that probably could be done with a
Mhm.
smartphone. But I don't, it's a great idea. So behavioral activation, so it's basically, you know, how do the patient's behavior, so if you remember the trap track cycle, how do those behaviors work for them? How do they not work for them? And focusing on the here and now, so what are the current behaviors, how are they functioning currently, and how can we intervene in those behaviors and replace the maladaptive ones with adaptive coping strategies. So this just goes back to that trap cycle and adds track, which is active coping. So it's, you know, in response to painful emotions, rather than the avoidance patterns, one engages in active coping. So in behavioral activation, there's a lot of work done on value identification and what are the things that you value that are helpful for you, enjoyable, relaxing, pleasurable, that make you feel better, and that both reduces the symptoms of depression, but also positively reinforce that coping strategy. So the more you do it, the more you want to do it because you feel better. And so this just goes back to the same thing. So I think if we look down at the bottom part here, so if you fail an exam, you feel sad and hopeless, alternative, you know, coping would be rather than isolate and feel bad and not do the things you like and don't go back to class, you get a tutor, you talk to the professor, you find a study partner. You know, those are alternate and adaptive coping. That leads to a sense of mastery and you feel better, basically. And then the next time because you're using those strategies, you get a better grade, you feel joy and mastery, and you're more likely to do the same thing. So it's reinforcing to those alternative strategies. So medications for depression and anxiety. Medications, I mean, there's a ton of medications. It's relatively a simple topic because evidence-based medications it's a small group. So for depression, selective serotonin reuptake inhibitors, so going back to that synaptic cleft, these are medications that increase the amount of serotonin that's in that space between the neurons by interfering with their reuptake. So the ones that are hanging out in the synaptic cleft get pulled back into the originating neuron and recycled, basically, and this blocks that, so there's more of them in the cleft. So common ones would be sertraline, which is Zoloft, fluoxetine, which is Prozac, citalopram, which is Celexa, escitalopram, which is Lexapro, and paroxetine, which is Paxil. There's another one that's used mostly for OCD, which is called fluvoxamine, which is Luvox. Then serotonin norepinephrine reuptake inhibitors, same idea, but it expands the reuptake inhibition to include norepinephrine. Those are venlafaxine, which is Effexor, and duloxetine, which is Cymbalta. And then there's mirtazapine, which is kind of a combo strategy of different ways of enhancing serotonin, and bupropion, which includes then dopamine, and that's Remeron and Wellbutrin. So anxiety, it's the same list for the first line treatments. So the same SSRIs, the SNRIs are very effective for anxiety, and there's some nuances in that, but basically it's the same treatment. This is the important thing. Second line treatment are buspirone, which is Buspar, and benzodiazepines. Benzodiazepines are prescribed a lot, but they're not first-line treatments for anxiety. So benzodiazepines are things like Xanax, which is alprazolam, and Ativan, which is lorazepam, and so those are commonly used, but there's also clonazepam, which is Klonopin. They're very effective, but they're effective immediately. They make the anxiety go away, but there's no learning involved, and there's some potential for abuse and dependence with benzodiazepines, so that would include Valium as well, and some older medications. So what I want you to remember is just that SSRIs and SNRIs are the first line treatments for both depression and anxiety. Now, if they're not effective, there are all sorts of other strategies, but those are the first line treatments. So this one we don't need to do. So a few words on prevention, and we'll have 10 minutes left for questions. So this isn't really prevention, this is really recognition, but the best proactive treatment for depression would be to recognize it early, because then effective treatment can occur, which decreases both the duration of that episode and the disability associated with it. Reoccurrence rates are high, especially for young people, so at least 50% recur within 2 years and 70% within, or 75% in 5 years. The more episodes you have, the more your risk is for future episodes. So CBT, so I talked about this a little bit earlier, but CBT after successful treatment, so you treated your depression successfully with a combination of CBT and medications, which actually is better than either alone. So you can, if you compare head-to-head, fluoxetine, which is Prozac and CBT for depression with adolescents, they come out the same. You add them together, you get a boost. So it's important to know that combination treatment is better than single treatment, especially for more severe disease. So anyway, you're successfully treated, then engaging in CBT, whether you had CBT during your treatment originally or not, probably decreases relapse risk, and it makes sense because you're recognizing those psychological triggers for depression. And then just having CBT seems to have an enduring protective effect. So I always want people to think of CBT as like the lifelong strategy. You do it, you practice it, you keep going with it. Medications, for a single episode of depression, you take them for 6 months to a year, you're done with medications. But treatment can go on throughout your life, self-directed, if you know the principles of cognitive behavioral therapy. And then there's some newer research that suggests that, what we think SSRIs do for us may be actually less than what the whole amount of what they do. They might actually protect our neurons by other factors, which might involve the immune system and other neuroprotection. So I don't think we know all there is to know about the medications we use to treat depression. I don't think anyone would disagree with me. We know the basics. Teaching kids about anxiety is protective. So teaching them about anxiety means that anxiety is normal. Everyone gets anxiety. Anxiety is not dangerous. So we always say it's not dangerous, it's temporary, not an emergency. It can be adaptive because it helps us prepare, remembering the Yerkes, dots, and curve, whatever your smartphone is going to be doing to you. There are actually good apps. There are CBT apps for phones, so there's a lot of stuff that is out there that can be helpful. But kids knowing that anxiety is actually good for you. There's an advantage to the fight or flight response, because that outpouring of epinephrine helps, dilates our pupils. So if it's dark out, we're able to be more effective in escape. It sends blood flow from our gut to our muscles. There's a lot of things that the fight or flight does for us that has helped us survive as a species. But when it's a problem when our bodies are reacting, they're misfiring, which happens in panic disorder, to non-dangerous situations as if they were dangerous. Lifestyle is important, although the evidence to say that you can treat depression or anxiety with lifestyle is scant. So I wouldn't over-rely on it, but prospectively, in terms of prevention, I think there are lifestyle changes that anyone would benefit from. So most of the evidence about diet and depression suggests that it's the Mediterranean diet that's effective. So, if you take a large cohort of college kids they're not depressed, it's just a huge number of them, and you follow them through life, you can show that the percent adherence to the Mediterranean diet, so it's not total adherence, it's just the closer they approximate, the closer they get to adherence, the higher their adherence, the lower their rate of depression onset. So that, it's very suggestive that the Mediterranean diet, which is plant-based, plant oils, meat is more of a condiment, nuts and legumes are a big part of the diet, it tastes good. You can go to Italy. That's an important diet for a lot of reasons, but it's probably somewhat helpful for prevention of depression. Exercise, that's not controversial. Exercise helps both anxiety and depression, and it doesn't have to be, whatever the latest really high power exertion is. It's 20, 30 minutes doesn't even have to be aerobic. Exercise is helpful. Complementary and alternative treatments, people always ask about them, but it's really hard to get research to demonstrate the safety and the efficacy of most of what we consider complementary, like supplements, et cetera. So you'll hear people who say that was really helpful, but there's not convincing evidence that any of them really are. Thank you for your attention. Are there any questions? Yes?
You mentioned, you had a slide that showed 75% relapse within 5 years, but if one is on longer term of the medication, then, and continues cognitive behavioral therapy, whether within a session under a doctor or change behavior, change the results, that statistic would change, would it not?
Right. So because of that statistic, people who have a single episode of depression, they're not going to be on antidepressants the rest of their life. But if they've had 2 episodes of depression, they would probably consider longer term treatment with antidepressants. If they've had 3 episodes, they should be on antidepressants for life. Because the cost of depression, not just dollars, but to health, all the things we've talked about, is great. And the risk of long-term antidepressant use is, it's never been shown to be risky long-term. Any other questions?
Regarding treatments, how about making sure you get enough sleep at night? Where does that sort of fit in the scheme of things? We seem to need it.
Yeah, no, that's a great point, and it didn't even occur to me as I was making that slide, but sleep restoration is really important in the treatment of depression, of bipolar disorder, of anxiety disorders. So sleep restoration, actually CBT is good for everything. CBT, there's actually CBT treatment for sleep. But sleep restoration sometimes includes pharmacologic interventions. Many of the pharmacologic interventions for sleep are not very helpful, actually. They knock one out, but they don't provide the deep sleep stages 3 and 4 that we need for restoration. So I'd be cautious about sleep medications, but sleep hygiene is something that is really important, and that's, it might sound obvious, but you decrease your caffeine intake. You typically stop napping during the day because sleep isn't like a bank account. So if you're having trouble sleeping, people often get into the habit of taking naps. If you must take naps, they should be less than 30 minutes because that doesn't allow you to get into a deep sleep cycle. So actually they're more restful too. So the cat nap is very much more restful than a 2 or 3 hour nap, because if you try and wake up from a 2 or 3 hour nap, you're already in stage 3 or 4 and you're just groggy and feel worse. So eliminate naps or make them short. Usually not increasing body temperature prior to bedtime is helpful. Now, it's not true for everybody, but things people do that increase their body temperature, which is, like taking showers or exercising a lot right before bed. If you think about we all have biorhythms, and our temperatures actually drop, our body temperatures drop as night comes. So it's like a mini hibernation, if you will. So increasing your body temperature actually isn't helpful for sleep. The biggest thing that people, besides for caffeine, probably, and alcohol is not good for sleep, so people who have a good stiff drink to help them sleep, they might sleep, but it's not as good. It fragments sleep stages, so not a great strategy. Screen time is something that disrupts our sleep more than we think. So the light that hits our retina that's coming from those screens is actually very stimulating. So there are screen covers, I think, that take the blue out, so they're kind of orangey things. But the best strategy would be to eliminate screens of any kind, TV screens or computer screens or cell phones even an hour before it's bedtime. And then the other obvious things are dark, quiet places to sleep. Maybe not so obvious, if you're lying in bed for more than 20 minutes, you should get up and sit quietly and read a book or do something very relaxing or boring, and then try again when you're tired. But you don't want your body to associate your bed with being awake. You want it to associate it only with being asleep or other activities, which is a church. Any other questions? Yes, ma'am.
What are the cognitive behavioral therapies for depression? You can recognize how bad it is, or?
So cognitive therapy would look at those schemas and the distorted cognitions. So you'd identify how your thoughts in today or this part of your life are affecting your mood. So you recognize those cognitions cause your mood to be more sad.
So depression is never just a chemical thing. It is also,
So if you think of somebody who has, if it's a chemical thing, but this is really cool. You can demonstrate with CBT. So CBT alone, you can demonstrate on MRI scans or functional MRI scans, you can demonstrate changes in brain structure volume. So that means without medications, you're changing your brain through a therapy intervention. So that suggests to me that it's never all or nothing. But if you know somebody who's been chronically depressed, even if it's totally neurochemical, they develop patterns of thinking which are consistent with their depression. So they get into those depressive cognitions. So even if their depression, they take their Prozac and their depression improves, those patterns of thinking have become concretized, or they become relatively permanent. They need to be addressed for full recovery or optimal recovery. So that's a different way to think of it. So I just would never look at it as all or as none. Yes, ma'am?
I have a question for, what I wanted to know is that the anxiety and ADHD have a high risk to become depression, or is it automatic, or can be prevented?
Yeah, so life experiences can lead to depression. Anxiety and depression are often comorbid. ADHD only indirectly leads to depression, so I don't think I meant to say that ADHD leads to depression. So let me start over. So anxiety, people with anxiety commonly have depression. Sometimes that depression could be seen as the response and sort of the normal response to their restricted life activities. So if they're staying indoors, they're not functioning at work, they've underperformed in the work world, they never have achieved what they could have because of anxiety, or they're not involved in relationships because of anxiety, they often are depressed. People with depression often have anxiety, and that's just about the biology. People with ADHD, so if you think of a kid with ADHD who's untreated, they're an 8-cylinder car firing on 3. They know something's wrong, but they can't perform. So it starts in childhood, and they're behind their peers. They can't keep up in terms of assignments and academic performance, which is their work. What makes us feel good? A lot of them work. Their work is being in school, and if they can't compete with their fellows, and they eventually they start to think that they must be not as smart, they must be failures, et cetera, they underperform. When they get their driver's license, they have a higher rate of accidents. They tend to start hanging out. It's sort of a downward course, untreated ADHD, or it can be, and that may lead to depression. So that's how I would see ADHD leading to depression. Yes, ma'am?
I have a question. When the depression episode happens, how can the loved one help the person to get out that, cope with that? Because it seems to be nothing work, no matter what we do.
So I think loved ones obviously are the other people affected by these diseases, because they're dealing with somebody who's maybe at risk for suicide, but maybe not functioning in life. So what I would do is try and help them get help. I mean, I think that's the most effective intervention, to help them overcome whatever barriers exist to get treatment. Empathic listening is really helpful, but that's a road to help them get treatment, I think. And, learning cognitive behavioral therapy is probably not helpful to other people because they need to want that intervention. So responding empathically and validating emotions and stuff like that is being a good friend, that's helpful. But trying to be their therapist probably isn't, but helping them get to treatment is the most important thing in my opinion.
And we are going to have 2 sessions during this series that are specifically about how to support people with mental health challenges. Specifically that idea of compassion resilience, or helping family and friends learn how to take care of themselves so that they can help the other person. And so that, just given the series overall, there are going to be some other components that will be helpful over time. These are huge topics, so I think Dr. Luhn did such a good job.
Thank you all for coming.
Go Packers. Packers. Sorry to the Packer fan up here. But anyway, great information. I just want to give you a couple of bits of detail. We do have extra PowerPoint presentations for your notes in the back if we ran out on the front end. We'll also have it available on the website, and as you saw, we did have a video. So please take some flyers as well, or spread the word, because I think these other upcoming presentations about suicide prevention and that self-care, more prevention, are going to be really valuable as well. But this gives us a great foundation for our knowledge. We understand some of the physical aspects. So thank you for coming, and go Packers.